My project was on using the heterogeneity, or looking at the heterogeneity of treatment effect across different diabetes drug classes, and it is an extension of the Legend study. Okay, next slide. And then you can click to, I guess you could click through 3 bullet points or 4 bullet points. Okay, so type 2 diabetes affects more than 525 million people globally. And as part of the community, there was a Legend type 2 diabetes study done in 2024, which investigated the relative treatment effects of different anti-hyperglycemic agents. However, we also know that diabetes patients are a heterogeneous group. And so people have different baseline risks, demographics, comorbidities, et cetera, which could all modify the risks and benefits associated with those different drugs. Next slide. And so our question is, do the risks of health outcomes differ based on patient characteristics? And so to figure out this research question, to answer this research question, we extended the original Legend type 2 diabetes studies, and we looked at treatment effect estimation and stratified by different clinical and demographic subgroups. Next slide. And so our study design followed that of the Legend type 2 diabetes study. So we looked at adults diagnosed with type 2 diabetes who initiated treatment with one of the anti-hyperglycemic drugs. So there's 9 different drug classes, but if you click next, Craig, these are the 5 drug classes that we actually had sufficient people in to do the analysis on. So those are the 5 that actually ended up making into the analysis. Next. Okay, and then we looked at 11 outcomes of interest, which are which is a subset from the original type 2 diabetes study. And then next, and these are our subgroup of interest. So the different subgroups we're going to potentially look at to see if there is a heterogeneity of treatment effect. Okay, next slide. And so briefly, how did we quantify what is a heterogeneity of treatment effect in the study? Well, we calculated pairwise hazard ratios for each target, comparator, outcome, subgroup combination. And I'll talk a little bit about that in the next slide. But briefly, for those of you who are not familiar, a hazard ratio is where you compare, I guess, 2 different drugs in this case. So a target drug, which I'm calling sulfonylureas, and a comparator drug, which I'm calling GLP-1s. And then you'll get some hazard ratio. So in this case, hazard ratio for an outcome. So in this case, let's say the hazard ratio was 1.5, then what you would say is that the risk of the outcome is 1.5 times higher for the target versus the comparator. Okay, next slide. And so we calculated these hazard ratio for all the different target, comparator, outcome, subgroup comparisons. And then to find the heterogeneity of treatment effect, we would take 2 subgroups. So for example, female and male, we would take the log of those hazard ratios and then find the difference. And so next slide, I have an example. So in this case, our outcome is stroke. Our target and comparators are biguanides and SGLT2 inhibitors. Our subgroups of interest is patients who have hyperlipidemia versus no hyperlipidemia. If you can click next, Craig. And so as you can see here, we found the 2 hazard ratios corresponding to those subgroups, and those just compare the risks of biguanide versus SGLT2 inhibitors for the outcome of stroke. We took the log of those hazard ratios and we found the p-value. So the interpretation, next, is in this case, because the p-value is significant, that there is a differential effect in the hyperlipidemia versus non-hyperlipidemia groups when comparing biguanide and SGLT2 inhibitors for stroke. So this is the type of analysis that we did to quantify whether or not there's a heterogeneity of treatment effect within the subgroup. Next slide. So for our results, we had 6 different databases that we ran an analysis on, 5 of which passed diagnostics. Hyperlipidemia, hypertension, obesity, sex, and age were the groups that passed diagnostics. Many of the other subgroups did not pass diagnostics. And then of the subgroups that did pass diagnostics, all but age had some evidence or some signals where outcomes exist and a heterogeneity of treatment effect. Next slide. So there's too many subgroups to talk about every single one of them, but the good thing is the whole table is in the brief report on the OHDSI website. And in general, what we found is that these subgroup comparisons and where there did exist heterogeneity of treatment effect, it aligns with known pharmacologic patterns. So for example, in the obesity subgroup, we found that obese patients have a greater benefit on biguanide versus DPP-4 inhibitors against hospitalization with heart failure events. And we didn't see this sort of pattern with non-obese patients. And this kind of makes sense because clinically, we know that biguanide, or metformin in this case, is known to be weight loss positive, whereas DPP-4 inhibitors are more known to be weight loss neutral. So maybe for obese patients, they have more to gain by being on biguanide versus DPP-4 inhibitors. And now for the sex subgroup, we found that female patients have a higher risk of diarrhea of GLP-1s versus DPP-4s and sulfonylureas versus DPP-4s. And we didn't see that with male patients. And we also saw that female patients have a lower risk of stroke on SGLT2 inhibitors versus DPP-4 inhibitors. And again, we didn't see that for male patients. And so kind of, if we think about it, maybe this makes sense because in the literature, we know that female patients usually report adverse events more than male patients, or maybe this could reflect, the second result could potentially reflect a differential risk in cardiovascular disease between male and female patients. So that's what these could potentially be from. Next slide. So some key takeaways and next steps. This is meant to be a hypothesis generating study. We did find a lot of null results. Some databases did not pass diagnostics. However, we also found some interesting subgroup comparisons and potential evidence of treatment heterogeneity, which means that there is also potential for personalized type 2 diabetes treatments in the future, which is good. And lastly, just want to put in a plug for the power of OHDSI and large-scale studies. And of course, none of this could have happened without the community, the tools, the collaboration, and everything else. And so, yeah, thank you so much for listening, and let me know if you have any questions.
Thank you, Cindy. We have a few minutes here. Does anyone have any questions? And I'll remind, lightning talks, posters, brief reports, which are the abstracts, are all available on the Global Symposium homepage and the Collaborator Showcase page. Evan, go ahead.
Cindy, thanks so much. Can you hear me?
Yes.
Oh, great. What do you make of the lack of findings in the age subgroup? I mean, I'm trying to kind of wrap my head around that. Is that something that you guys expected?
Yeah,
it seems like a lot of those things would kind of otherwise. I don't know. I just find that to be an interesting result, and wonder if how you guys have squared it.
well, one of the issues I realized after running the study, because we had written the protocol and decided to do it one way, sent out to collaborators, so we can't really go back, is the age subgroups are kind of divided up funkily. So there's young, middle-aged, and old. And I wish I would have divvied up to be even more granular, because the old subgroup is anyone greater than 60, the middle age is from 18 to 60 or something like that. So the age subgroup divisions didn't really make sense. But in the brief report, I do kind of specify more what the age divisions are like, and I'm kind of thinking that could be the issue.